I'm a pharmacist by background and have been practicing as a pharmacist for the last 20 or so years. I have seen and worked in a variety of different areas. Everything from academia, teaching pharmacy students and medical residents and medical students, to working in health systems, working in pharmacies, hometown pharmacies, mail order pharmacies, chain pharmacies, and I worked for the state for a little bit. Throughout all of this, we've seen the invisible hand of these pharmacy benefit companies and how they essentially mirroring what happens in the medical space with insurance companies and how they influence prescribers to pharmacists in the pharmacy benefits world on how sometimes how they, what they can say to patients, how they care for them, and for pharmacies, how much money they make. Pharmacies don't get to set the price for these medicines. They actually get paid whatever the insurance company says that they'll get paid for medications. So we said, we're going to go and talk to these employers that offer close to 60% of the healthcare that people around the country get access to healthcare through their employers. And we want to go talk to these employers and let them know that through their decisions, they are either hurting their local communities because of the healthcare vendors that they choose, healthcare partners that they choose for their health plan, or they can help their community. And we've established this cost plus relationship with local independent pharmacies, a network of about 20,000 pharmacies across the country, and now also includes grocer pharmacies. And you can do it in a way that helps your community and helps to uplift them and help reconnect your members away from mail order. They don't have to get their drugs in the mail. There's nothing special about that, to getting medications and having a relationship with a pharmacist in their community that can help them out, whether that's a retail pharmacist at one of the big box chain stores, or it's one of these mom and pop pharmacies. They're an advanced primary care organization, and they set up primary care clinics exclusively for large employers across the country. Employers that manufacture, have manufacturing plants with thousands of employees. They now have their very own primary care clinic right near their workplace locations. And now we've embedded a virtual pharmacist here to help support the members of those clinics and the staff and the providers at those clinics to help enhance the care that they provide education, support, better health outcomes, and then, of course, access to savings programs that we've built for employers as well. So that's a little bit of everything. I apologize, I rambled on a little bit too long.
That's a great setup.
I have a few things I want to ask about right there, actually.
So today you could get a drug that's a penny, and we'll tell you that's a penny drug, and they got 30 pills of that, so it's 30 cents. And that's just what the pharmacy's buying the drug for. Or it's a $1 drug, or it's a $10 drug, or it's $1,000 or $10,000 drug. But now you get to see clearly, without any obfuscation, without any other manipulations in price, exactly what the pharmacy's buying that drug for. And then that's the cost that you pay the pharmacy to buy the drug for. And then you have a dispense fee, or the margin that the pharmacy makes to get that drug to your members. And now you see clearly, just crystal clear, we don't put that cost basis on. We use a national average drug purchase price that the pharmacies are buying this for, national average price that the pharmacies are buying it for. So we use that as the cost basis, not tied to us. We don't set it. It's actually maintained by the Centers for Medicare and Medicaid Services through surveys that they do across the pharmacies across the country. And we use that as our cost basis. And we thought the future is virtual care. Virtual is going to replace everything. We're never going to have to go back and see a doctor again. A ton of money flowed to all these health tech startups that were doing virtual care. Plenty of bad actors that sort of took advantage of the system and the way that the lax rules that were there around that at the time. But now you come into late 24 or 24 and 25, all those regulations get put back. As Warren Buffett would say, is that you can see the companies that aren't swimming with any clothes on once the tide goes back to the ocean. And yet now you start seeing all these health tech companies just sort of falling apart, closing shop, scandal ridden, so on and so forth. And so some context. It is a real struggle for mom and pop pharmacies to survive today more than ever, and it's only gotten harder over the last 15 years to survive as an independent mom and pop pharmacies. If you follow pharmacy news or healthcare news, you know that you've probably seen some really well-known established pharmacies that have been around for decades, over 50 years, just say, look, we can't afford to keep our doors open because of how bad it's gotten with insurance companies and their reimbursements primarily, and then all of the other sort of barriers that exist in being able to provide care. However, with that said, a third of all pharmacies in the country are still independent mom and pop pharmacies. We have 66,000 pharmacies in the country. About 20 to 22,000 pharmacies are mom and pop pharmacies. They're more prevalent in rural areas and suburban areas than they are in urban areas, but they do exist, and they're just, again, holding on by a thread.
This has been a Shut Up production.
Shut up!